So anyway, I'm Amanda Martin. I'm the Executive Director for the Center for Rural Health Innovation. And I'm really pleased to be here today.
And I'm Steve North, and I'm a family doc and adolescent medicine specialist, and I'm the medical director for the Healthy Schools program.
All right, so without further ado, didn't work. Try again. Agenda. There it is. All right, so the things we're going to run through here, this is all related to school-based telehealth. I want to explain to you my assumptions about who I'm talking to today. That may not be where most presentations start, but that's where I wanted to start today. We've kind of introduced ourselves, but we'll also tell you why we feel like we have any authority to give any information or advice about school telehealth. And then we want to talk through clinical readiness, those consent to treat forms, protocols you should have in place, communication plans, estimating visit numbers for your first year and maybe beyond. And then a couple of hot tips that I just couldn't leave off of the presentation, some resources for where you can get more information besides just emailing me, which of course is okay too. And then some time for Q&A at the end. And we have an hour, right, Rob? All right. So starting here,
that's correct. Sorry.
That's great. Okay, thanks. We'll keep an eye on the time. So my assumptions related to who I'm talking to today, and I hope I don't have this way off, but this is what I understood, is that there are a lot of programs that are ready to start school telehealth, not just crafting it, not getting together information for a grant, but you're ready to go. So I prepared our remarks based on these assumptions: that your funding is secured, you're not here looking for grants, that you have funding for equipment and operations, because it's not just about equipment, and that you've chosen what you're going to put in the schools. And then this is an important one, that your new best friend works for the school IT department. And I hope that you cooked out last weekend and you're best buds, because I suspect that your equipment is not going to work very well in the schools if you have not already connected with school IT. And I would further suggest that you not wait until school starts back to go find out who that person is. They may be 12-month employees, and they may be very happy to get started on your connections early. The MOU or MOA with the school districts is worked out and signed, or at least there's a draft on the right person's desk. That can't wait too long. And that you're credentialed and otherwise set up to bill insurance. So this is really the list of things I'm not talking about. Because I'm not prepared to describe how Kentucky Medicaid is going to handle your claims, because I am not the expert on that. And then your program is staffed or will be staffed with providers and coordinators. So I'm assuming you have all of these things ready to go, and you just need that really solid checklist of how to have a really great launch in the fall.
Great. Now, if this was me, if this was my program, I'd be like, got to get that one. Got to get that one. And we're happy to help you out and give you some tips about that down the road if you need them. And we'll have email addresses after the meeting.
Absolutely.
Yep.
So Healthy Schools. So this is the name of our program. Healthy Schools started in 2011, offering services, but actually started before that with Dr. North's efforts to figure out how this could work, if it could work, what the needs really are in our community here. So we're in Western North Carolina. We're in the Southern Appalachian Mountains. Not quite all the way south.
Yeah, we're sort of based halfway in between Asheville and Boone, with the Blue Ridge Parkway running on the southern end of two of our counties, and the Appalachian Trail on the northern edge, bordering on Tennessee. And it's rural and small schools. When we started, one of our schools had 60 kids. And that school is closing this year, and they're consolidating some schools. But as I think is happening everywhere, we've got long distances, and both of our initial counties, and actually all of our current counties, are HIPSA counties. So in 2011, we began with a pilot program with our first iteration of telehealth equipment. We have some lovely TMS servers sitting on a rack in the school district. If anyone would like those, send a self-addressed stamped envelope and they're yours. But and we have grown from 3 schools serving about 75 kids in our pilot year to, as of school closing yesterday, we were in 88 schools in 6 counties across the state of North Carolina, with our highest volume ever. I think 1,100 visits this year, roughly.
More or less.
Yeah.
Yep. So we've been at this for a little while, and in addition to running the Healthy Schools program, I have, like Rob said, gotten to help lots of different organizations across the country set up programs. And so while it's easy for me to talk about how we do it in ours, and our way is this way, obviously our way is not the only way. And I do have some familiarity with other ways of doing things and some ideas. So if you get stuck on something, don't hesitate to ask. All right, so we'll carry on here and dive into the content. So starting with, is the clinic ready? This may be the super easiest checklist ever, but I want to just highlight a couple things. First is obviously training your presenters, right? How to use that telehealth equipment. And this training may come from the vendor. It may come from videos that the vendor sends you links to that you can train them on. And that's great. I would make the case that your providers also need to be trained, not just on how to do the provider side of the software and the encounter, but also how the equipment actually works. Even though, arguably, in most cases, your provider, your nurse practitioner, your MD, whoever it is not going to be the one actually holding the camera in the kid's ear. They need to know how it works.
But you need to be able to explain to the presenter how they could turn the back of the otoscope so that you could see the front of the tympanic membrane a little bit better. And so there are those things. And the other thing about training providers that I'd stick in there is that seeing a 5-year-old for an ear infection virtually is very different than seeing them in the office.
How so, Dr. North?
Oh, why, thank you. You need a little bit of showmanship. You need to keep the kid engaged and
involved.
Involved.
Is that like the on the screen, off the screen?
I'm not giving away all my secrets on this webinar, but yeah, that works.
Okay.
But I think that you need to keep that in mind, that you can't all be buried in your EHR at the same time you're seeing a patient on the screen.
You have to look up.
You got to look up. You got to try to make some contact and a connection.
Okay. So important to train them, and don't assume that just because they're a good provider in person that they just automatically will know how to do this.
Absolutely.
Now, it's probably not any harder than the EHR or email or shopping on Amazon, but you just need to know how to do it.
You just need to work through it a couple of times, 2 or 3 visits, and you're comfortable.
So that's where we get to the scheduled mock visits. And this is something that that our program has found as we've introduced new equipment and added in new school nurses. You can do a group training, right, where everybody has their equipment in front of them and there's one person up front talking and they all have a binder and checklists and they're learning in a group. But these are adult learners, right? And we all have learned that we don't all learn really well that way. And I have found that a lot of school nurses, who are mostly our presenters, are not going to be real quick to put their hand up in front of their peers and say, I don't know how to do that, or can you show me 4 more times? So it becomes really important to have a mock visit scheduled so that there's some individual training available. And that lets both sides practice a couple more times. I encourage the school nurses to present themselves, present a colleague, the school secretary, their own child. Whoever's not sick and whose ears don't hurt is really my recommendation.
Always a good person to present. Yeah.
Somebody whose ears don't hurt.
Yeah.
So those workflows need to be prepared, but also, don't print them off on a PDF and save it that way, because they're going to change. You're going to figure out that they're going to change, but I would have them ready. And the workflows start from when a child maybe is sent from their classroom to the school nurse's office, or whatever the scenario is going to be for you all. It's not just the workflow of actually presenting the child or the patient, but how do they get into your program? Who's verified that they're enrolled? Who has scheduled the appointment? And which entity that's involved in your program owns that piece of it?
And that scheduling piece is really tough. And we have an amazing woman who works for us, Lacey Jones, who we couldn't do this without, because you're scheduling the student, trying to find when they can step out of gym versus their math exam, the nurse or other presenter, when is that individual at the school? And then when it's February and you're trying to cover multiple schools where there's a flu outbreak, when's your next slot? So trying to coordinate those 3 schedules can be a major task.
And they're all owned by different entities.
Yeah. And I think that the workflow issue is really important for a provider who may only work with one presenter a couple of times a month, so that it's not every time, well, now could we go and do this? And I like to do this next. But that there's sort of a standard set in that visit of the vitals are done beforehand. I read them off, tell you the chief complaint. You then talk to the patient at length, whoever that
Mhm.
patient may be, and if the parents there talk.
But if you didn't have a checklist, like Dr. North just didn't have a checklist, you might forget to do introductions.
Oh, right.
This is Timmy Smith.
Yep.
This is Dr.
Absolutely.
North.
Yeah. And some assurance of confidentiality that this isn't live streaming on Periscope or somewhere. And then just working through the physical exam and what is and is not needed. And then how's it going to wrap up and who makes the closing phone calls?
Right.
Yeah.
So the next bullet point on here in italics is who do you call when it doesn't work right? And whether that's on the provider end or on the presenting end,
Mhm.
the scheduling, somebody needs to own that, and their cell phone number needs to be prominently displayed on all of your materials. Just a hot tip there. And then having supplies in place, deciding what you're going to do. We're going to come to that in a minute a little bit more. But having test kits in place, disposables in place, and ordered those little specula that go on the otoscope. Those things, they're not rocket science, but they need to be in place. And then, of course, if you're going to use alcohol swabs to wipe down things, make sure that those are in place. They may already have them if you're in a school nurse office, but you shouldn't assume.
And school nurses don't have a whole lot of money. So
Usually
anything you
not.
can bring to help them.
If you're not already employing the school nurse and providing all their stuff, you might be surprised at what they don't have. So clinic equipment for vitals. So I was amazed to learn that most of the school nurses in our first couple of school districts did not consistently have scales,
Mhm.
and they did not consistently have blood pressure cuffs, or they might have one, but it's the one that they had from when they were in training
Yep.
some years ago, and they only have one size cuff.
So it doesn't fit a 6-year-old.
Just saying.
Yeah.
Or some of the faculty and staff who they were trying to help out,
Yep.
but who had bigger arms. So make a comprehensive list of what vitals you want to collect. If you want O2 sat, then get the little things and make sure they have them in batteries.
Mhm.
Don't forget the batteries. Did everybody write down batteries?
Always good.
Good. Yeah.
Yeah.
Scales, the batteries. And you may become a big hero for providing scales in the nurse's office, because now the whole group that's walking every day at lunch and trying to lose weight, they stop in and check their weight. And
Absolutely.
it's a resource to the school. I've been amazed how we can be helpful. Okay, so moving on.
Consent to treat. So one of the keys to school-based healthcare is that we're not just going out and pulling every kid who's got a runny nose in to be seen. It is important that you have parental consent, just like you would in a practice. You need to make sure that the consent outlines that the parent can be there in person, or perhaps you talk to them on the phone beforehand and definitely afterwards, but know what is happening and that you are authorized to do so. We do not see any kids, with the exception of some adolescent health issues that are federally protected around mental health issues, without parental consent. And so having this form available and sending it out and having it available in multiple ways, because Mr. Jones, who swears that Tom is a football player and he never gets sick and he's going to be just fine, doesn't need this service whatsoever in September. Well, come October and his asthma's acting up and they can't get to the doctor, you need to have that consent. So is it available online? Can it be completed through a portal if you're that tech savvy as a small organization? What things can you do to decrease as many barriers to treatment as possible? Because that's why we're there in the first place, is to eliminate that big transportation barrier.
Right. And I would say, as a horror story, I heard about one program that was trying to get set up, and they said, well, as long as we have the paperwork 3 days before the appointment, we can get them entered into the system. And I thought, now, how is that increasing access to care? That seems like a bit of a joke to me, because there's no way that it takes you 3 days to input the amount of information that a parent's going to scribble on a sheet of paper. Because arguably, if I go down to the urgent care down in the next city away from us, and I walk in, they're going to hand me a clipboard and I'm going to fill that out, and I'm still going to see the provider in 10, 15 minutes, maybe an hour, but not 3 days. So don't make it harder than it needs to be. Make sure you're putting it in the languages that your communities need. I don't want to assume what those might be, but around here we use Spanish. And then the key thing, if you're going to send a piece of paper home with every single kid in the schools you're serving, make sure it goes home with the whole packet of paperwork that they get at the beginning of the year. All of their free and reduced lunch, their bus routes, all of the things that they need to fill out, go ahead and make sure your form is in there too, even if it says optional. I can recommend putting a QR code right on the cover sheet so that they could scan it and go to your electronic form, because it's less paper coming back to you. But make sure that you've thought through how that's going to work.
So what do you do with the paper when it comes back?
I hope somebody's going to collect them. Some programs, the school nurse owns it.
Okay.
Right? The school nurse receives all the papers back from their school, they file them away, and they've got them on hand.
Mm-hmm.
When the time comes that a child from that school would like to be presented, the school nurse faxes that or scans it or whatever to get it sent to the provider office.
Okay.
So that's one way to do it. The way that we do it is that my staff, which is separate from the school district, separate from the hospital system, we're our own entity, we go out and we collect in all these papers. So, I'm already shuddering to think that in August, we're going to go pick up some, 10 or 15,000 pieces of paper.
Uh-huh.
It's going to be great. And it's a nightmare. And we're trying to sort through them and see if anybody's information has changed. And are there new enrollments? Are there updated? Yeah. Yep. I wouldn't call that a best practice, honestly.
No, I don't know if there is a best practice.
I don't know.
In my office, my rural health center practice, we don't have a best practice around how you get new patient information in and updated. And we all know the frustration of folks who struggle with monthly phone bills and have their number change every couple of months. Mm-hmm. And the challenges that poses with keeping in touch with families.
Absolutely. And then think through what you're going to do if you do get enrollment forms back where they filled out the front and they didn't turn it over and sign the back, or they filled out the first 2 pages but didn't get to the 3rd page and actually sign it. I can't tell you how many times that happens. So to work out a plan for how that's going to go, we've done several different things. Send them back to the classroom teacher, with everything highlighted. Sometimes we make a copy and keep it and then mail it to the family and say, would you sign here, and mail it back in the envelope we've provided you. We've tried all kinds of different things. I can't say that any of them work better than others, but I will tell you that the people who work in the schools you're serving, they probably know. They know the literacy level of the community. They know how parents are expecting to be communicated to. So it would be foolish to not ask them because they know. So we're talking about informed consent with this consent to treat. We got a question, which I'm just going to go ahead and tackle here, which is about immunizations. And I will tell you that despite many years of trying, we have yet to figure out how to give immunizations via telehealth. It just doesn't, they don't squirt out of the computer, right?
Right, but I think it is about coordination of care.
Yes.
Because our goal is not to eliminate the medical home. And so getting patients back to the medical home for annual wellness visit, EPSDT visits, is where the immunizations can occur. Partnering with schools around flu shot immunizations and other immunizations is another great way to do that.
Right.
But there's not a great way to do HPV for 2 patients a month at the small middle school in Pender County, North Carolina, and have those, the private stock and the state stock and everything else. We would love to find a program doing this well and hold them up as an exemplar and then steal their ideas.
Yes.
Yeah.
And we'll share it with everybody.
Yeah.
But so far we have not worked out how to do that, except to link back to the primary care provider and medical home. Couple other things on the consent forms. Consider exactly how much insurance information you really, really need. I suspect that we all, as adults, have gone to fill out the clipboard of paperwork at a doctor's office and been asked to copy down all the information off of our insurance card, knowing perfectly well that they're going to scan that thing as soon as I walk back up there with the clipboard. So make sure you ask for what you really need. If you just need to know the name of the company because you're going to look it up anyway, then do that. Because a lot of times a parent can give you the kid's name and date of birth and that they have Medicaid, and you won't even need anything else because you can find out. Your electronic health record will be verifying it anyway. So it doesn't matter what they write down. And then the other thing that I would consider is how much health information you expect to be filled out on a form that goes in the backpack and back to the second grade teacher's, inbox. Because parents who feel sensitive about their children's health history may not want to write it on a piece of paper that who knows whose hands it's going to fall into, because we can't protect it from the time they, get on the bus until they actually turn it into you. but it still could be sensitive information. So it's a good idea to have a way to have those mailed in. We make sure our address is on there. You can mail this form into us if you want. And I only get a few here and there, but it has made a difference for some families. It's not that hard to include our address.
And it's critical that you have the patient's primary care provider listed.
Got to know who they are.
Yep.
And if we don't get it on the form, we ask when we see them. All righty. I'm going to go on to the Dr. North part of the show. Can we talk about this?
Thank you.
Yes.
So one of the questions I often get asked is, what diseases do you treat via telehealth? And I find that to be a challenging question to answer, because my goal is to not put up any barriers to patients being seen. When patients come into my office and see me, they don't say, I have a left lower lobe pneumonia. They say, I've got a cough for 3 days. I get short of breath climbing the stairs. I think about symptoms first, and then through history, exam, looking at vitals, I work towards a diagnosis. I don't like putting people who, especially school nurses, in the position of diagnosing, or the presenter who's an EMT, who is also, the bus driver and the football coach. You don't want them to have to diagnose, well, you said your ear hurts. They treat otitis media, but outer ear infections aren't listed, and you got stuff running out. I'm not sure if you can be seen. That's not fair. And the key is to have the referral system in place if there's a problem afterwards. So when we train our nurses, we say, we want to see the kids unless, there's active bleeding, they have a fracture, they're unconscious, things where you have emergency protocols at the school in place to use. When Timmy falls off the jungle gym, Amanda's favorite victim in all these stories is Timmy.
Always talk about Timmy.
He suffers a lot. Timmy, if his arm is badly bent, probably needs to be seen in person so you can lay hands on that arm.
We shouldn't even hear about
Probably don't need to hear about that. No. If they're concerns about a concussion, though, and nothing else, that's definitely something that could be covered by a comfortable provider via telehealth with a skilled presenter. So, there are challenges with pre-diagnosing. Now, one of the things that's happened over 8 years is that while our grade school nurses are not pre-diagnosing, they're screening the patients. Mm-hmm. The patient who comes in and says, I have a sinus infection and I need antibiotics. Gail Ellis, one of our great nurses, will say, well, how many days have you had symptoms? 2. Have you had a fever? No. What color's your mucus? Clear. It might be allergies, it might be a virus. Come back and see us if things worsen, or it's been 7 to 10 days, because she has been in the visit so many times where our nurse practitioners say, you might have sinusitis, but you don't qualify for antibiotics, and so here's supportive care.
So they're learning.
They're definitely learning, and the patients are learning and won't come. But that's one of those situations where they're not diagnosing, they're doing a good job of screening. And they are in a way a gatekeeper. And we can talk about that role down the road as we talk about numbers and comparisons. So pre-diagnosis is tough. And beyond that is the temptation of the CLIA wave test in the office. Because we have done this for years, and we continue to run into trouble where you get the call, well, Johnny came down with a sore throat. His mom said he gets strep every time this year, and I went ahead and did a strep test. Oh, and both of his sisters at home have strep. So I now have a strep test. I don't know the answer to it, yes or no.
You mean the presenter has
the presenter has done the strep test and is calling me to say, here's the patient. And then they say the strep test is negative. And I say, oh, great. What do I do now? You've done a test that based on history, based on 2 siblings with strep throat, and if I looked at the throat and seen the patient, I may not even have ordered that test. And now I say, well, I'd like to prescribe antibiotics. And the nurse said, well, I told mom already the strep test is negative. I'm stuck. But what happens if it's positive? Well, why do you need to see the kid? Why are you going to bill me for a visit? You've already, it's strep.
Right.
In a practice where the providers know the patients. I previously practiced in a place where if patients had urinary tract symptoms, they may just drop off a UA and we check it and prescribe antibiotics for long-standing patients. And I think as antibiotic stewardship has evolved over the last 15 years, we move more and more away from that type of empiric treatment or treatment without a history and a physical exam. And so in the setting of strep tests, UAs, I stress to the folks that in our program that they really need to be done in the context of a visit or preliminarily, if the patient is scheduled for a 10:15 visit and you want to get a urine at 9:55, that's great. But we're going to talk about that all in the course of the visit, not share the results beforehand. So one of the challenges we face, and I'm transparent about this, where we fall down, is the negative strep test. We cover 6 counties. The 4 counties in the western part of the state that we cover are bigger than the state of Rhode Island contiguously. And standard of care from the American Academy of Pediatrics and in my practice is if a patient has a negative rapid strep and they're less than 18 years of age, it gets sent for additional testing. And that can either be PCR or a culture. We don't have the capability of doing that. There's not great data on serial rapid strep tests. So if you don't feel better in 48 hours, come back and we'll swab you again. But we do the best that we can to provide that care. And there are those situations where we have yet to figure out a solution. The high school microbiology lab is not the place to grow out strep cultures for patients.
That could be fun, though.
It could be a great experiment. You're absolutely right. They're more interested in like what comes off the screen on their cell phone.
That's true.
Yeah.
So to be clear, the tests that I've heard about being in school-based telehealth programs are obviously strep and the urinalysis.
Yep.
And then the flu tests, maybe.
Flu test, maybe. It's expensive. And often with CDC guidelines, you're not going to treat regardless of what the result of that test is. And Tamiflu is less effective than we probably thought it was. So I would really think through with your medical directors when you're going to treat and when you're not. We've worked through this for my health systems virtual care program at great length. Yeah.
But then in our community, we've also run into resistance from families to accept a diagnosis of flu
Absolutely.
that didn't include a swab.
Right.
And we haven't figured out quite how to re-educate the entire population about the importance of a flu test.
Right.
Or the need for a flu test.
Yep.
So just a heads up that you may be surprised how that turns out. Are there any other tests that you're aware of being done like this? Even if we don't do them here.
I think that depending upon your patient population, thinking about having pregnancy tests available.
Pregnancy tests.
Yep.
Okay.
And state laws. We're not allowed to dispense contraception on on school grounds.
In the state of North Carolina.
In the state of North Carolina. Yep.
And we can't really speak to Kentucky, but I'm sure y'all can figure it out.
And then, are there other tests that you'd want to do because of something that you were, you had an area with an outbreak of chlamydia and you want to start doing urine chlamydia? But that's something to work on an individual program basis.
School by school.
Yeah, school by school.
Program.
Yeah.
Okay.
Yeah.
So we're not doing blood draws.
Nope.
Although we could probably figure out a way to make that happen, but we're not right now.
Yep. Which is a challenge when doing, adolescent visits around obesity and hypertension, because the recommendations are after age 11, every child have a screening LDL. So, yep. And if unfortunately, their only source of care, how do we get that taken care of?
We got to be able to do it for them, but we're not doing it right now. Not saying it's impossible, but we're not. Okay, so let's move on, because we can always come back. I would encourage y'all, if questions come up as we're going, to throw them into the chat so we can address them kind of at the end. All right, so as you're rolling towards the launch of your new program, and as I was saying before, in my imagination, y'all are all going to start the first of the school year in August, September. I hope that you have a communication plan, media plan, and if you don't already have all of these pieces, here's the things I would add. To have your press releases written for newspaper and for radio. Around here, I mean, our program is very rural, and around here, a lot of people listen to the AM station. That's a really valid, good way to get information out to our communities.
And if you can get on right after the obituaries.
At lunchtime.
It's a great time.
That's when everyone has the radio on.
Yeah.
And we're not kidding even a little bit. But having those pre-written is a great way to go. And I would even encourage you to write the one for the launch of the brand new program, but also write the one for the end of October. Go ahead and write it now while you have time. That is going to be about how it's been in existence for a couple of months. And now that flu season is coming, where everyone's starting to get sick, make sure that you swing by.
But in writing that in advance, recognize that the first 6 weeks of school, the majority of the school nurses that we work with are tied up in their other sort of more public health and student body health responsibilities.
Right.
So asthma action plans, immunizations, vision and hearing screening, EpiPens.
Yeah.
And your numbers may not reflect their interest in the first 6 to 8 weeks. So don't get discouraged.
Right.
And we've got a beautiful set of graphs that show over 8 years, our first couple of years, we saw 2 patients in September.
It's heartbreaking.
And then one year we jumped up to 30 and we celebrate. and we're still seeing, 100 in December and January, but those first couple months, there's so much else going on. But as you become part of the culture there, those numbers begin to change.
So don't be discouraged on that. But I would have the press releases ready to go. The parent notification system in this, I don't know what it's called in your community. I've heard lots of different brand names, but this is basically the thing where the school principal leaves a recording that gets pushed out to every family that says the water main broke, school's dismissing at 1 p.m. or there's no school this morning because of snow. Whatever that system is, a lot of the schools are increasingly using that for other notifications.
Yep.
So we have found that if we will write them and script exactly what we'd like to have said, we can get the superintendent or the principal and sometimes even the school nurse to record those. So it's a familiar voice going out to the family saying, hey, don't forget the school telehealth program is available to you and all you have to do is ask for it.
Yep.
Or whatever your message is at the time. And we've actually written a year's worth of those so that we have them ready to go and to re-push. We also, along the same lines, pre-write emails to staff and to high school students who all have school-assigned email addresses. And we have those scheduled to go through the year. And they generally don't come from anyone on my staff. We give them to the school, so it can come from the principal or from the school nurse to the whole staff or to the whole student body. More likely to get opened, I guess. So don't forget the backpacks, especially in your elementary and maybe middle school age, especially elementary. They probably have a folder that gets opened at least once a week by a parent. You should make sure your piece of paper is in there. Enough said, right? I think we all are familiar with that.
Your children brought home those folders?
Up until 5th grade, they sure did.
Yeah, good, great. Better than mine.
If your school has a website, if the schools you're serving have websites, make sure that there's a link to your program on there. Social media, whether it's your own entity's social media channels or the school's social media channels, or maybe both. And don't forget that every post can be scheduled, especially like through Facebook. They can be scheduled in advance, so you don't literally have to put it up at the right time. Right. That can make that a lot easier. You can plan those out in advance.
Also, building on social media is when parents or students have good experiences. Asking them to share on social media can be really powerful. We've had a couple of parents who have shared their experience, and we've seen little bumps in utilization in that school and a change in the sort of willingness of parents to consider us an option for care. Yeah.
If at all possible, get someone from your team invited to staff meetings. Maybe your school district has a principals meeting to present the program and information to the adults who take care of these kids every day. Because you won't reach the kids if you're not going through the adults. So make a point of getting in front of them.
And building on that, our program is built on family nurse practitioners. And we're able to see teachers, staff members, etc. They like our program because they don't need to leave for the sinusitis that's been present for greater than 7 to 10 days or other issues. And they become advocates for the program as well. So as you're considering your staffing models, I know this is a more pediatric focused call. There is a real benefit for addressing the health of the school district employees as well.
Right. And so arguably, if you need to make a case for this. If you think about that, if Timmy, bless his heart, misses one day of school, that's one day of school for one child. But if Timmy's teacher misses a school day, that's one day of school for 24 kids, or however many sections of math she teaches.
And subpay.
Plus subpay, plus the sub plan, which I understand. I've never been a teacher, but I understand from teachers that sub plans are just about the worst part of being sick. Okay, moving on. Make sure that you get yourself invited to PTO meetings if your schools have them, or PTA. If there's a parent night, a back to school night, any opportunity to set up a table and give out pens and show a demo. Got to have a video. Even if we've taken just a monitor and a laptop and played a 1-minute video on a loop, just so that parents could see the equipment and kind of get an idea of what it was. I've been to football games. I've been to basketball games.
Yep.
It's miserable, but it's got to be done. It's got to be done. I don't know.
And kids love seeing inside their own.
They do like to see.
That is a huge thing. So if you can bring your otoscope device and show off the ear, that's pretty cool.
It can kind of pull them in.
Yeah.
But I would write it all up in a plan and schedule out at least the first 6 months or so if you possibly can. We found that to be helpful because once you're in the thick of it, it can be really hard to stop and take time to craft something meaningful.
All right.
Okay, so you want to talk about use numbers?
We'll talk about utilization.
Everybody really wants to know. I'm really proud of this graphic. Steve has not seen it yet. This is...
Wow.
Nope, that's not it.
Oh.
That's it.
Okay, good.
Wait,
I didn't understand what that
this
first one meant.
That's the standard deviation of a bell curve.
Thank you.
Yeah, that's not the one you want.
Okay.
This is the one you want.
All right.
All right. So what the gist of this here is that however much time you have a school nurse or presenter, we can use that interchangeably, in the school, some portion of the kids they see are going to be either sick or injured beyond their scope of care, but not all of them are going to be enrolled.
Okay.
So I may not actually have the math right here, but you got to consider all of these. And then that whole thing multiplied by a factor of how easy is it to make it happen.
That's a great way to look at this. Yeah, much easier than the standard variation. Or deviation of a bell curve. Yeah.
So I'm really proud of my little graphic because I found an online tool that would let me make this. So if anybody needs that, I can stick it in the chat box because it was really fun. Anyway, moving on. I wish I could tell you, if you have a school with 500 kids and the nurse is there 100% of the time, then you're going to see exactly this many kids per week, per month throughout the year. I dream of having that data, but I'm afraid it doesn't exist.
And it's about relationships. We have 2 school districts, and we've been in both of those districts for 8 years. And one district consistently presents 3 times more patients than the other. And
all other things equal.
All other things equal. School district size, there are actually more school nurses in the district that doesn't present as often. And even in the higher presenting district, which is our greatest one, there's a huge variation between the school nurses based upon comfort level, time, level of engagement. So really figuring those things out helps you. I'm not sure that fits into this equation, but it's got to be one of those gestalt things.
It's kind of the ease.
The ease, yeah.
And I would say that your presenter's ease is going to be based on how engaged are they really? What do they perceive the need to be?
Yep.
And are they really, really on board, or are they bobbleheading? Do they nod and smile and say, that sounds great, when they're in front of their lead nurse or their boss or the principal?
Yeah.
But they're never going to plug that thing in. And we may or may not have run into a couple of school nurses that never plugged it in.
But it worked great.
Totally worked great. Really, and they're super happy about it, and the kids are going to be really pleased to have it. And they said all the right things, and then they never did it. And so in our model, the school nurse is a filter,
advocate,
bottleneck, advocate.
Right, it can be a variety of things.
Lots of different things, and those are all going to impact how many kids you see. The other thing I would say is keep in mind there's some lovely national statistic. I probably should have put it up in here about how many actual visits the average American kid makes to a medical provider, any medical provider in a year. And it's
NHANES data, so one of those big data sets, and it's 1.6 visits per year. And that's the medically complex kids who are seeing somebody every month, as well as the kid who hasn't been to a doctor in 3 years, all lumped together. So you're not going to see 50% of the kids twice a year and be able to break even as our initial projections had hoped.
That would have been really nice.
Yeah, and we found that data, 3 years after launch. But still thinking about your role and how you can be a member of the community is really important.
So as you're estimating, think about how much time the school nurse can actually carve out, or your presenter, whoever that is, how much they can carve out, how many slots you really have at the provider side, and do they match up? Because I'll tell you right now, in case you haven't thought of it, a provider who has openings after 4 p.m. does not do a school-based program any good at all. But sometimes neither does the 7:30 slot because they haven't even gotten off the bus yet, or they're just getting off the bus. So it's important to match up availability of both. There's a lot of pieces to that. Okay, you ready for the, oh, it did work. Okay. I call this final tips. It doesn't mean we're going to stop talking. And we're still, of course, happy to take questions. But I wanted to run through a couple more things. A lot of our kids have Medicaid, which means that they can go to the pharmacy, their prescription is there waiting for them, they pick it up at no cost. But sometimes what's going to really help a kid feel better is not something that can be prescribed. It's cough drops. It's snort lozenges.
Excellent.
It's and it may be a thermometer. And I'm pretty sure that you can't prescribe any of those and get Medicaid to pay for them. They're not expensive, but a lot of the families that we serve don't even have the $5 or $8 that it would cost to buy a bottle of Tylenol and a thermometer just to monitor and feel better. So I would encourage you to think through if you have any solutions for that. What we have done is we've established relationships with a couple of local pharmacies in our communities who will furnish the over-the-counter items along with the prescription, say, and send us the bill. So the parents still go there, they still are having that relationship, and I can ask questions at the pharmacy. And the pharmacist can also make sure that they get the right kind of Tylenol, that they buy the children's versus the baby drops versus the chewable juniors, whatever. And that they get the, what do you call it? Not name brand.
Generic,
yeah.
There's also a role for our uninsured kids
Absolutely.
who need an antibiotic and an inhaler and a spacer. And we have some resources to be able to help out with that as well.
Right.
Often generated from local foundations in our counties that say recognize the need.
Right. Or if a church can scrape together $500 for a donation, it goes into that medication pot in our bookkeeping. And I would encourage you to think through that because you can do a lot of good evaluating and diagnosing, but if the care plan doesn't get carried out, then really what have you done?
Yeah.
You've put some cool equipment in a school. So speaking of care plans, one of the things that we do, and I think a lot of the school programs do, is that you evaluate and you diagnose, you prescribe even, maybe you prescribe, but somewhere in there, the provider has got to talk to that parent guardian.
Absolutely.
Because you've got to verify, even if it was written on the piece of paper, you've got to verify the allergies, you've got to verify, what's already been tried, the present history. How's it go?
History of present illness. Yeah.
I'm not clinical. Can y'all tell? And make sure that what the child reported coincides with what the parent guardian reports as far as it's been 2 days or it's been 2 weeks, those sorts of things.
Right. And the need for that changes as the child gets older and you can hopefully get more information.
Out of a 16-year-old compared to a 6-year-old?
But you often can. No, gotta ask my mom. Like, dude, come on.
But that phone call is a really important part of our care process because you're also then our provider is going to verify who's the PCP and what pharmacy would you like for me to send this prescription to?
Yeah,
those are kind of important things. But then there's always this question: what are you going to do if the parent won't answer the phone? And I will tell you a couple of tips on that because you can't make people answer the phone. We make sure that we have a number we can leave them. They can call after hours because we know that some people's work does not allow them to take a personal call. So it's going to be after 5 or 6 or 7 before they can call back.
And that would be my phone.
And we make sure that it is documented in the encounter note that the provider tried to call.
The other thing that we do is ask the school nurse when they're talking with the parent to say, if you get a phone call from a number in Spruce Pine, North Carolina that you don't recognize, answer it today.
Just go ahead and give it a try.
Because Timmy's really sick and you need to talk to the doctor about it.
And that's going to be our provider calling.
Yeah.
But I would just encourage you to work that out in your planning of how you're going to manage that. We always send the encounter note to the primary care physician office, right? And we do that unlike other online, out there national models that say, if you log into our portal, you can print off the note and then you can take it to your PCP.
Mm-hmm.
If you go to the Walgreens or CVS walk-in clinic and they say, oh, here's a copy of your note, you can take it to your PCP. We don't mess with any of that. And we strongly encourage you not to mess with any of that, but rather send it independently. Go ahead and send it. It's part of our consent. We say we're going to share the information. And wait for it, what if they don't have a primary care doc? We work on that too. We do the best we can to help connect families to providers in the area who are taking new patients, who accept their insurance, and we try to connect the dots for them.
Yep.
Make sure you have ready to go your excuse, right? This is something that we were a good ways into our program before we figured out we needed it. An easy way to have that piece of paper that the front desk at the school, separate from the nurse, wants to have to document Timmy has been excused for the rest of the week. Or Timmy needs to go home today, but he should come back tomorrow. Are you only writing him out for one day? But that needs to be something, since you can't hand that to them at the checkout counter in the traditional sense of a clinic, it's important to work out how to do that.
The other thing to work out there is patient education. And so how do you have pre-printed forms about lice, viral URIs, et cetera, that the nurses can just have in their office and send home?
Why aren't you giving me an antibiotic for this?
Right, exactly.
Yeah,
yep.
And it's already printed out and ready to go. And we'll just put a few copies, 10 or 15 copies in a folder that the school nurse has ready. So our provider can say, oh, hey, nurse, would you please also send home in his backpack a copy of that piece of paper? And then this is maybe a no-brainer for program people. You already know this, but data collection is important. And I want to encourage you to think about what you would ever like to know about your program down the road, even if your funder didn't demand it, and even if you can't collect it with your electronic health record. For example,
go ahead.
One of the things that our program started collecting in year 2 or 3 was how often we had trouble with our equipment. Whether it was an equipment problem, like this camera worked yesterday and now it won't turn on, or connectivity, like bandwidth and lag time and latency. And so we started tracking that after every visit. And we were able to take that data to our vendor who provided the equipment and say, no, your stuff is failing 40% of the time. It's not just us. It worked yesterday.
Yep.
And so that's been powerful. It was also useful when I needed to write a grant to replace equipment, and I had really detailed info about how often we had trouble with it. Other things we collect are who exactly presented. Was it the school nurse or was it a presenter from somewhere else?
We also record the outcome for the patient.
The disposition.
So was the patient sent home or did they return to class? Because really what we're trying to impact is academic performance, high school graduation, and have a positive outcome on seat time. So right now, about 87% of our patients get sent back to class, and it's totally appropriate. You should not have that be 100.
Yeah, don't go for 100.
Because, kids with 101.5 and active strep need to go home for 24 hours. They need to have their first dose of antibiotics before 3 p.m. so they can return to school the next day if they are afebrile. So that's...
There you go.
Yeah. So that's the kind of, stuff you want to record. Are you going to see them in follow-up for something? Did you need to contact their PCP?
Right. And those
directly
are things
about hypertension or
we've not found the right box to check in the EHR that we can then also turn around and report out on. So we have a super low tech method to keep track of this. It's a little bit techy. We use SurveyMonkey. It's very glamorous. And after each encounter that our nurse practitioners perform, they finish their note, they shoot that note off to the PCP, and then they click on this SurveyMonkey survey and they fill it out. And we ask the questions exactly the same way every time. And we keep it as quick as we can. But then at the end of the school year, we can look at all of that and see You know, what is our return to class rate, and how well is the equipment performing, and whatever else you might want to know. We used to collect which day of the week they were seen on, because I was very curious if we saw, you know, more kids on Monday.
Yeah.
But it turns out we actually see more kids on Friday. But that's just, you know, that's just us. But now we can pull that from the electronic health record. At the time we couldn't. So I encourage you to consider what else you might like to know and how you can gather that information.
You want to jump to questions and then close out, or what do you want to do?
Well, I do want to talk about this. This is
Okay,
a couple
great.
other resources, and then we'll look at the questions that are on there. Now's a great time to type in your questions in the chat box if you would like us to come to them here in a minute. So further information, I would just make sure that you are aware of the School-Based Health Alliance, which has been around for more than 20 years, 30 years?
30 years.
And they are the national advocacy organization for school-based health. And they have tons of resources on their website. I don't think you even have to be a member to access most of their stuff. They have a meeting coming up later this month in Washington, D.C., which, you know, if you can drop everything and go to, that's wonderful. But otherwise, at least check out their website, because they can answer a lot of the questions about how to get in and around schools and kids. The Mid-Atlantic Telehealth Resource Center is one of the national telehealth resource centers that are federally funded telehealth resource centers that serves both your state and ours. Kentucky and North Carolina are part of Mid-Atlantic, which I think is kind of funny, because I don't think either one of us would consider ourselves Mid-Atlantic.
But I love coastal Kentucky. It's really, really beautiful this time of year.
It does, right on the Atlantic, yeah. But that is how we get to share a lot of information about what we do. That there are a lot of resources about telehealth through the Mid-Atlantic Telehealth Resource Center. Their website's easy to find. I put info@crhi.org. You can reach either one of us there. The next slide actually has our direct email addresses. But I will tell you that a collaboration exists between our organization and these two, School-Based Health Alliance and Mid-Atlantic Telehealth Resource Center, to put together a center of excellence, which is such a fabulous name, but basically it means a website with all the best practices. And that's coming soon. It should be released in the next couple of weeks. And so if you'll keep an eye on these sources, you'll see that when it comes out.
All right.
So let me put it on the last slide, which has our beautiful logo and my email address and Steve North's email address for your follow-up questions. We'll do our best.
All right. So a couple of questions from the chat box. First one, if a Medicaid student has a different PCP, do they need a referral?
That's a Kentucky
And
thing.
Tim, that's a Kentucky thing, and I don't know the answer. From UKK 128.
That's Rob.
Oh, that's Rob. Thanks. I may have misled people. I practice at a rural health center. That is my day job. I'm the medical director there.
And a physician.
As a physician, yeah. Nights, weekends, 2 o'clock on a Tuesday afternoon when I can slip away, I see patients through our school-based telehealth program and help lead it, which is an independent 501c3. In the state of North Carolina, F2HCs and rural health centers cannot be the distant site in a telehealth encounter. In some states under Medicaid, that is possible, and it would make our program much more successful if we could do that. It would add another layer of administrative work as well, so that's sort of a double-edged sword. Are you seeing encouragement of direct-to-consumer telehealth with your students, with parents, employers, or health plans? I would say that we're not. The majority of the students we serve have Medicaid and don't have access to the direct-to-consumer platforms. If anything, those platforms are helping to make telehealth a more acceptable modality. When we launched the program in 2011, those platforms did not exist. Now, for employers over 500 people, 95% of them offer that as part of their insurance plan. It's on television ads for United Healthcare on a regular basis. People think about it and are more comfortable using it. Yeah.
So it's actually helping us by educating the population that we want to serve about what telehealth could be, which eases our way a little bit in coming in and saying, yeah, but we're local.
Right.
And we're actually, in your schools as opposed to on the sofa. Do we have any other questions at this point? Oh, here we go.
Oh, great. Which telehealth vendor have you guys come to use after all these years of experience? We'd be happy to talk with you about that offline. That's not what this venue is for. But we have a lot of experience and have been through 4 iterations, at least, of our telehealth equipment.
Mhm.
Yep.
Thank you for the question, though.
All-encompassing vendor supply telehealth equipment, or is it a Frankenstein-created system?
Oh, yes, both.
Both.
We've done both. So currently, our current iteration is a whole package, right, where we're using the software and the equipment all in one go. In the past, we have done some various...
When we started, we had this otoscope that looked like a laser gun. And it got hot the longer you used it because it was a fiber optic light source. The nurses didn't like that too much. And so when we moved to an otoscope that looked and felt like an otoscope, but just had a camera off the back, it worked so much better.
Right.
Yeah.
And we have definitely done the kind where we had a codec with a big monitor and then separately a laptop so that the stethoscope could hook into the laptop. Let me just say, that by a factor of ease, I would think about what you put together maybe cheaper if you Dr. Frankenstein it together. But are you going to be able to support it that way? And does your training for your presenters become really, really complicated? We've done it both ways.
We've done it both ways. And I think that with a robust video conferencing platform that you could use multiple cameras on and multiple mic sources, which can therefore be your stethoscope, you could run this all off a laptop for, a couple $1,000 at the most, setting it up.
Right.
Yeah.
Right.
Yep.
Because keeping in mind that we're not trying to take pictures of moles to determine whether or not to do surgery for cancer.
Right.
It's not that level of
level of detail,
quality of image and that sort of thing. I mean, it would be nice.
But you're probably going to take that quality picture off your phone.
Probably so.
Yeah. All right.
We're closing in on the hour. Rob, do you have anything to add, or did I miss any questions?
Looks like we don't have any more questions. Guys, as always, thank you for the time today. It's very helpful. We had a great turnout. At one point, we had 79 people, or 79 connections. So, great turnout. Thanks to everybody who joined. Again, we will have the recording available. We'll make note of where that's going to be, but I think we're going to have it on our website. So more information to come for everybody. But again, thank you guys for the time.
I'm so glad that we could, and we'll look forward to seeing your follow-up questions after.
That'd be great. Thanks, guys.
I'll send the slides.
Thanks,
Bye-bye.
guys.